Um, so I have called this talk Clotting in Long COVID Evidence and Perspectives. And I really want to emphasize there's a lot of perspectives and maybe less so on the evidence side. But hopefully it will spur some good conversations. I'm also aware I'm in a room full of highly qualified people, including haematologists. So I want to emphasize this is my take on the evidence so far and some of my perspectives and perspectives of my colleagues. So to start with my disclosures, as I am of a group called Team Clots, who is fronted by Professors Rizia Pretorius and Doug Kell, who have patented the microclots measure. I'm also a vaccine-induced long COVID patient, and I've benefited significantly from clot-targeted therapies. I would not be able to have put this presentation together, let alone present it, if I wasn't on these treatments. So I've obviously got a little bit of a bias about the benefits these treatments can bring. And I do run a business giving long COVID consultancy, but I don't profit from any clot targeting therapies. So when we think of clotting in long COVID, we often think of microclots. They're usually the thing that's in the news. These are small clots of misfolded fibrin, and the type of misfolding is known as amyloid, and it's commonly kind of abbreviated to fibrinoloid. We know amyloid proteins from other diseases like tau amyloid. These are just misfolded bits of fibrin. They have some interesting properties, and the first interesting thing is that they're very difficult to break down. We find them in other conditions that are inflammatory of nature, such as rheumatoid arthritis. So there's a question about whether it's just a downstream effect of inflammation or whether there is something unique to COVID or the spike protein. What we tend to find in COVID is that the microclots are bigger, more numerous, and more difficult to break down. So there might be something unique to COVID-related pathologies. The idea that these could cause health problems is that they primarily occlude small blood vessels. And what we think happens is that this impairs oxygen extraction, causing energy dysmetabolism, and that might result in the higher lactate levels that we commonly see. And for those on Twitter, you might have seen the hashtag the acid test. That's a group of patient scientists, including myself, who are collecting data on lactate levels in long COVID, ME, and post-vaccine syndrome to see if we can understand whether lactate relates to any of these symptoms or whether there's any trends that we can start to pass out a little bit. We also know a very recent study came out that showed after exercise, there was microclots actually in the muscles, and after exercise, this caused muscle necrosis, which maybe supports the idea of impaired metabolism. Another idea is that microclots kind of seem to act a bit like vacuum cleaners in the blood, and they just soak up everything they come into contact with. So there seems to be entrapment of inflammatory proteins, antibodies, and other proteins. And some people have speculated that this might explain why we get so many normal test results. I'm not entirely convinced of that, but it's an idea. And then we have to think about the common relapsing, remitting phenotype that we see in long COVID and ME. And there is an idea that this might be caused by widespread, almost micro ischemia reperfusion injuries. And this is where there is a blockage of the blood clots block oxygen extraction. And then the blood clots clear and you get an influx of oxygen, and that causes oxidative stress and cell death. So that's one idea. And this could also potentially explain why there's exercise intolerance is quite common in long COVID. And if we think about the effects of exercise, you'd get a vasodilation, so it might allow more microclots to get into the capillary. And then after exercise, you get a vasoconstriction, which might then trap the microclots and cause hypoxia. And to kind of support this idea, there is quite a lot of evidence of vascular remodeling in long COVID. And the main biomarker that's quite often talked about is VEGF, which has roles in angiogenesis. And we think what might be happening is the blood vessels get occluded, and that results in new blood vessels being formed. But because the clotting hasn't been treated, the process just repeats itself. Now, when we think of clotting in long COVID, microclots often gets the attention, but in my opinion, it's more complicated than just microclots. And the next thing I think that's often kind of underappreciated is the role of platelets. And we have seen quite a lot of hyperactivated platelets in long COVID patients. Platelets are often seen as just plugs that fill the gap, but they're really interesting molecules. They're very similar to mast cells in that they're granulocytes. They contain chemicals and they release those chemicals. And some of those are very similar to mast cells as well. So, for example, they release neurotransmitters, particularly serotonin, dopamine, and they release histamine, which again is very similar to mast cells. Histamine in itself can cause platelet activating factor expression, and that will then lead to platelet activation, which could then lead to more histamine release, and maybe that's part of why we get this perpetuating cycle of platelet activation in long COVID patients. What I think is also interesting is platelets or platelet activating factor has roles in allergic type symptoms, it has roles in seizures, and it can cause low blood pressure. So again, these are all very common things that happen in long COVID, and there's huge overlaps there with how mast cells act. Platelets are also implicated in a lot of neurodegenerative diseases such as Alzheimer's, Parkinson's, and MS. And some researchers have likened platelets to circulating neurons because the way they interact is very similar to neurons. So I think there's quite an interesting role that platelets might have to play in long COVID. Then alongside all of this, we have endotheliitis, which is inflammation of the blood vessels. And I'm sure I'm preaching to the choir when I say that the endothelium is more than just a tube. It's a very bioactive organ. There's ample markers consistent with endothelial damage in long COVID. The markers of endothelial damage often correlate with symptom burden, and hyperactivated platelets can amplify and sustain endothelial damage. So when I think of clotting in long COVID, I'm not thinking about any one of these things. I'm thinking about how they all interact, and I kind of dub this the trio of chaos. Now, one critique of microclots theory is that there is some overlap. Some long COVID patients have fewer microclots or a better microclot score than healthy controls, and equally some healthy controls have more than long COVID patients. Now this could be explained by probably more things, but two main things. One, that this subset of patients, microclots isn't an issue, but the other thing might be that if you're healthy, you don't have the platelet hyperactivation and the endotheliitis, which means that you can handle a larger microclot load without it being pathological, whereas you might not be able to handle quite such a load if you've already got rampant hyperactivated platelets and endotheliitis. Then we think, thinking back to the other inflammatory diseases that have microclots as part of the physiological milieu, we have to think, is there something unique about COVID? And the obvious thing is the spike protein. And we know that when we put spike protein in platelet or plasma, it induces microclot formation and platelet activation. So within this, we can look at different strains of SARS-CoV-2, and Omicron in particular is an interesting one because although it's more transmissible, it's less harmful on average. And when they've compared patients who are who've been infected with Omicron compared to pre-Omicron, they find a reduced microclot area and reduced clot stability. So it kind of acts a little bit like an internal control, and suggests that the hypercoagulability of SARS-CoV-2 plays an important role in COVID pathology. So that's the kind of underlying ideas of clotting in long COVID, but how does this relate to the real lived experience of long COVID? So I want to talk about three main pathologies that typically come as part of the parcel of long COVID. So the first one is POTS, and that is a real oximeter reading of my heart rate going up some stairs fairly recently. So even before COVID, POTS was associated with endothelial disease, platelet pathology, tissue hypoxia, and thromboinflammation. So it already seems to be part of the POTS package. But some more mechanistic ideas of how clotting might actually cause POTS or contribute to POTS. Firstly, we have nerve ischemia. If we're thinking back to the capillary occlusion, it might lead to nerve damage, and that nerve damage causes the dysautonomia. There are some ideas that microcirculatory disturbance can cause sympathetic overcompensation. And obviously part of POTS is that we're not getting enough blood to the brain, and that's partly triggering the tachycardia. So if we're clotty and we're not able to extract oxygen effectively, it's just contributing to that brain perfusion. And I don't want to make any broad claims based on an anecdote, but my personal experience was that my POTS treatments were much more effective on clot targeting therapies. And I always wondered whether it was because now the blood can both get to my brain and it can perfuse my brain. Both times I've come off clot targeting therapies, the thing that gets worse is my POTS. So it's N of 1, don't take too much from it, but it does suggest there might be a relationship, at least in some patients. Amyloid proteins in general are neurotoxic, so there are some ideas that this wouldn't be any different for a fibrinoid protein. The endothelium is predominated by parasympathetic fibers, so if we're getting endothelial inflammation, then it's likely those fibers are the ones that are going to get more damaged. And again, that might link to the sympathetic overcompensation. This is purely my idea. I can't throw a ton of research at you, but there is, if you kind of make some inferential leaps, when you're in an ischemic state, choline seems to be released from tissues, and that might lead to choline depletion, which might contribute to B12 deficiency, which is known to be implicated in POTS. And we also know that there might be cholinergic dysfunction in some POTS patients. And this might also have a link to the hypermobility we see, since choline is needed for cell membranes. And then, of course, some POTS patients are predominantly POTS patients because they have a venous compression, and venous compressions are associated with clotting because you get stagnant blood. So if you're then introducing a prothrombotic stimulus, there's a question to be had about whether that's going to exacerbate the pathology that compression causes. And kind of linking to that is that veins have a higher density of histamine receptors, so they're more sensitive to histamine vasodilation effects. So if you kind of put those pieces together, it might be that hyperactivated platelets release the histamine, cause excessive vasodilation when you've already got venous compression, when you might already have hypermobility, and it just exacerbates things. The second main pathology is, of course, mast cell activation syndrome. I feel like I'm preaching to the choir here. But we know, obviously, the role of mast cells is to respond to change. So they're activated by spike protein. They're also activated by platelet activation and ischemia reperfusion. They are found in the vasculature, and they have a bidirectional relationship with the vasculature to regulate things like vasoconstriction. They're implicated in inflammation, vasoactivity, vascular leakage, endothelial cell activation. And the mediators are implicated in coagulopathy, which means, in my opinion, MCAS could be a response to or a cause of clotting in long COVID. And just to give some examples, we've already discussed VEGF. It has roles in angiogenesis, so it's creating new blood vessels as a compensation to clotting. Heparin is obviously an anticoagulant, so it could be responding to clotting, and it also has some spike binding properties, which obviously the mast cells don't know about, but it could be helpful in this context. Histamines induce tissue factor expression and they promote platelet aggregation, so they could be causing the clotting. Prostaglandins have both pro and anticoagulation effects, so that could go either way. Tryptase has roles in fibrinolysis, so it could be a response to clotting. And superoxide dismutase promotes protein C activation, so it could be a response to coagulate you. The final main pathology that comes with long COVID, and there are obviously loads more, is autoimmunity. And one paper has been published suggesting that the novel epitopes that the misfolded proteins create aren't recognized as self, and that creates an immune response. So from that, I want to give some perspectives, and these were largely published by myself and Dr. Robin Kerr, but influenced by lots of other research and other fantastic scientists. So what we proposed is that perhaps there's spike protein persistence, and a couple of papers have come out to suggest that in long COVID and post-vaccine patients there is spike protein persistence. And this is the kind of model we created, where if you don't get a long-term impact of COVID or the vaccine, you clear the spike protein and you're healthy. And if you can't clear the spike protein, it triggers the clotting cascade, microclots, platelet activation, mast cell activation, inflammation. These all interact with each other to cause what we commonly know as long COVID. But what this model doesn't answer is, why do some people clear the spike protein and why can't some people clear the spike protein? And this why might actually be the problem. The spike protein might not be the problem, but the reason we can't clear it might be the problem. This model also suggests that maybe in some people, treating the clotting could have secondary benefits at reducing mast cell activation. Following from that is when we think about microclot breakdown, what's actually happening. Now I said earlier, the microclots are hard to break down. They take 2 or 3 digestions in the lab, but they do eventually break down, and we'll see that later on. The treatments for it, things like apixaban, which won't break down the microclots, but it will stop the clot formation. So the body can break them down, but it's a very slow process. And then what might be happening, very speculatively, is that they release the entrapped inflammatory proteins, the hemostatic proteins, things like that, and that triggers clot formation and inhibits clot breakdown. So you kind of get this cycle where you can't really escape until you get treatment. And what some people have posited is maybe this could explain the lack of D-dimer release, that we quite often don't see elevated D-dimer in long COVID, and maybe this is the reason for it. I will say, without being a clinician, so not having the clinical experience, and maybe one of you can correct me when we discuss at the end, in my experience, what I commonly see is D-dimer levels of about 350. So they're not reaching the clinical threshold of 500 to say you're clotty. But when I have a 25 or a 30-year-old with a D-dimer of 350, that seems quite high to me, but that might be my naivety. But if that is a little bit high, I'm wondering if it is just this very low grade clot breakdown, but the clots are very small, so they're not going to be releasing a ton of D-dimer like a large thrombus would. So based on all of that, we proposed the term spike protein-induced thrombotic vasculitis. I will say that the talk last month, this term was attributed to someone else, and they plagiarized us in 4 different papers. We coined this term. The point that we were trying to get across with coining this term is that, first of all, it allows for subtyping by primary pathologies, because long COVID is not one thing for everyone. So I wouldn't recommend treating someone who doesn't have clotting with clot targeting therapies. So we need to start subtyping what is the primary problem. We also wanted patients to be taken more seriously. I think it's much easier to ignore a patient when they say they've got long COVID, but it's much more difficult to ignore someone who says they've got thrombotic vasculitis. And that in itself might be the thing that helps encourage treatment, because in virtually no other context is clotting left untreated. It doesn't matter what the cause is, we'll generally always treat the clotting and treat whatever else needs treating. And the problem that we have right now is that we're in an evidence void and we don't have necessarily the right clinical tests to say that we need to treat the clotting. And that makes for a very difficult ethical decision as a doctor, because how can you treat something you don't have evidence for when the evidence, the scientific evidence suggests that it could be a good thing to do, regardless of what your clinical tests show. So in terms of clinical tests, I would firstly say there are no validated tests for microclots directly, and I don't think there's any validated tests for the type of platelet pathology that we see. But I would say that we can look for supporting evidence for clotting. So I would generally start with the kind of obvious things to test for, and in particular, antiphospholipid syndrome. I don't know what the situation is in other countries, but in the UK, they tend to only measure anticardiolipin and lupus anticoagulant. But if you look into the literature on things like ME, which about perhaps 50% of long COVID patients have, and beta-2 glycoprotein 1 quite often comes up positive. So I do wonder whether we're missing some antiphospholipid patients. There is also some ideas that antiphospholipid syndrome biomarkers might be implicated in vaccine reactions. So I think that's an important one to check for. Then, particularly if a patient is presenting with breathlessness or desaturations, I would try and see if they can get pulmonary function tests. And the test I'm most interested in is DLCO. It's sometimes called TLCO. And if that comes back low, I would see if they could get a VQ or DECT scan. And these are more sensitive to the micro thrombi and the perfusion defects that we typically see in long COVID, compared to a CTPA, which would normally be done for pulmonary emboli. Then if you want some unvalidated markers, venous oxygen saturations is quite often used by clinicians who look at microclots. We tend to see in long COVID quite low venous oxygen. Figures I've seen are from about 15% to about 40%, when we would typically expect maybe around 60 to 80%. What the idea is that cells are so hypoxic that when they do eventually find oxygenated blood, they extract as much oxygen as possible. It might also be related if there is kind of ongoing micro-reperfusion injuries. That might make sense. I'm not 100% sure of the idea, but that's what people are suggesting. VEGF, as I've discussed earlier, lactate as a sign of dysmetabolism. I would just be careful to note that this isn't specific to very much. If it's just you get a high lactate, it doesn't tell you very much, but it might indicate something is wrong, and at least that's very validating for the patient. A mean platelet volume can be elevated if platelets are hyperactivated. It's non-specific, can mean other things. My mean platelet volume was elevated before my vaccine injury, and it just seems to stay high even on antiplatelet treatments, but that might be something you want to look into. And then in research, we have fluorescence microscopy of THT staining. The full protocol for this is patented, but Resia Pretorius will come and train you up if you want to start doing that. Jakob Laubscher, who works with Resia, he does TEG with platelet mapping. There's flow-mediated dilation and endopath for endothelial damage. And then there are markers like ANG1, p-selectin, and RANTs for things like platelets and endothelial health. What I would say, though, is screen for other pathologies too. I often find people get stuck on one idea. They might have multiple things going on and they all need to be treated for and screened. So check for things like MCAS, POTS, ME, venous compression, autoimmunity. But these are hopefully some ideas if you want to explore clotting. Obviously, they're not the tests we have in research, but you might be able to find something that warrants treating. So in terms of treatments, we have several lines that we can go down. The first one is anticoagulants such as apixaban or rivaroxaban. Like I said earlier, these don't directly break down the clots, but they inhibit the clotting cascade. So they're going to stop the clots being able to reform as they break down. Some anticoagulants might offer benefits over others. For example, heparin binds to spike protein. So if spike protein is the problem that's triggering the clotting, that might have added benefits. The bigatran has enhanced fibrinolytic properties over things like apixaban. Thinking about the properties of a microclot, it's particularly resistant to fibrinolysis, so dabigatran might be an advantage. And then we have fibrinolytic supplements, which do directly break down the clots. The one that's most often talked about is nattokinase. It's got some very interesting properties. Breaks down, at least in the lab, it breaks down spike protein, it breaks down microclots, it breaks down PI1, it breaks down biofilm. But nattokinase is a fermented soy product, so it's a very well-known MCAS trigger. There are other alternatives that generally seem better tolerated, such as serrapeptase, bromelain, or lumbrokinase. So if you're suspecting your patient might have MCAS, which most of them probably do, I would probably opt for a different fibrinolytic supplement, at least to start with, rather than nattokinase. And I suspect they all have very similar properties to nattokinase, they just haven't been researched as extensively. Then we have antiplatelet medications, which obviously inhibit platelet activation. P2Y12 inhibitors, such as clopidogrel, particularly good at attenuating the platelet and endothelial cell interaction. And as my picture at the beginning showed, that interaction might be perpetuating the cascade of dysfunction. And then aspirin, obviously aspirin blocks prostaglandins, so could have secondary benefits in MCAS. And it has previously been used in a model of vaccine-induced endotheliitis, and it was very effective if they used it before the vaccine. So it's well known to be useful in this kind of context. Obviously, the cautions with these drugs is, first of all, clopidogrel is a P2Y12 inhibitor. About 20 or 25% of users have genetics which make it ineffective. So you might want to think about alternatives like, if I might pronounce this wrong, ticagrelor. And although aspirin can be used as an MCAS treatment, a lot of MCAS patients are obviously salicylate intolerant, so they can't take it. Then there are a lot of other multi-targeted treatments. I'm not going to talk about them all, but I'm going to talk about two that are particularly interesting. First of all, it's SSRIs. They can have antiplatelet, anti-neuroinflammatory, endothelial supporting, and mast cell stabilizing properties. I think some caution needs to be warranted with these drugs. First of all, lots of patients come off them and have really bad withdrawal effects, or they have side effects while taking them. But second of all, I think there just needs to be caution when talking to this patient, because so many of them have been psychologized and gaslit and dismissed that they might think you're inferring they have a psychological problem. So I think if that's something you wanted to explore, just make it clear the reasons why you think it might be useful. The other one is statins. Statins have antiplatelet, anticoagulant, anti-inflammatory, mast cell stabilizing, endothelial supporting effects, and they can also increase cortisol, which is often low in long COVID. My caution with statin is that they do reduce the amount of CoQ10 people have, which is important for metabolism. Now, when they research this in a standard population who take statins, taking a CoQ10 supplement doesn't seem to have any notable effects. So I think the Q10 depletion isn't that significant. But again, about 50% of long COVID patients might have ME, and CoQ10 is already often low in ME. So if you're considering statins, I would, as a precaution, dose them up on CoQ10, just so that they're not depleting that on the treatment. Now, in the kind of clinical group and some of the literature, proponents of the clotting theory of long COVID support aggressive treatment, commonly called triple therapy. And triple therapy is usually one anticoagulant and two antiplatelets. But it can be a mixture of things, or they might also add something like a statin or an SSRI. This is obviously a very high risk treatment, and I would say that a lot of caution needs to be taken, and particularly something to protect the stomach, like a PPI or an H2 blocker. The reason I mention this is because a lot of long COVID patients, just in my experience, including myself, really respond badly to proton pump inhibitors. So if you start them on that, I would start them on the PPI first to check they react okay to it before you start the triple therapy. And if not, an H2 blocker will be good. That also has effects for activation syndrome. So finally, I just want to end off with some considerations. The best evidence we have for triple therapy right now is a case series of 91 patients. And about, I think 70 or 80% of them responded incredibly positively to treatment. There was one significant bleed requiring a blood transfusion. And so if this is a representative sample and we can extrapolate this puts the risk of a severe bleed at about 1%, which is perhaps give or take in line with dual therapy or even single therapy in some studies. So it doesn't seem overtly risky, but I say that with high level of caution that this wasn't the study to test safety. A couple of things this study did really well was, first of all, they subtyped patients. They didn't anticoagulate patients who didn't have evidence of coagulopathy. So they actually considered who they were anticoagulating. I think this is really important because the biggest long COVID study in the UK, the ICP trial, they are just classing long COVID as one thing, and they're randomizing patients to an anticoagulant, two antihistamines, or colchicine. And I just think how useless it would be to be given an antihistamine if your main problem is clotting. They haven't subtyped at all. So I think that was a real benefit of this study. They also monitored patients to check for hypercoagulability. But what they didn't do is check for long-term outcomes. So they did pre and post measures, but we don't know how those patients fared coming off the treatment. As a clinician, I think it's important to make patients very aware of what to expect when they start the treatment. And something to be aware of is that a severe relapse is expected, and it's usually around weeks 2 to 4, but it can be very variable. I know in my case, one of my relapses started about 7 weeks after treatment. We don't quite know what's happening in these relapses. One idea is that the inflammatory proteins from the microclots are being released, and that's causing some chaos. Another idea is this widespread reperfusion injury, and if that is the case, antioxidants might help, but we don't really know. Just based on clinical experience of my colleagues and my own observations in the community, the people who relapse tend to come out much better. They do really well on the treatment, but we obviously can't guarantee that. And I do know at least one patient who had such a severe relapse, they stopped the treatment and their baseline never recovered. Now, what we don't know is if they continued the treatment, they have come out better. So I just think that's a risk that needs to be considered and discussed with the patient. Then we also don't know whether there is actually unique benefits to triple therapy, or whether there are subgroup of patients who would do well on single therapy or dual therapy. And I do know quite a lot of patients have done dual therapy and done quite well. And we also don't know whether that's going to be safer. I know when it comes to dual therapy, some patients will have dual antiplatelets, others will have an antiplatelet and an anticoagulant. I know in my case, I need the anticoagulant and an antiplatelet, otherwise all hell breaks loose. But we don't know whether those on dual therapy would do better on triple therapy, or whether those on triple therapy could have just done with dual therapy or even single therapy in some cases. The length of treatment time also remains unclear. And just to kind of give an example of two extremes, myself and Dr. Robin Kerr, we wrote his case study up together. He had been ill for about 17 or 18 months and had a 2-month course of triple therapy and was effectively cured, or at least significantly in remission, could go back to work. I started dual therapy at around 15 months into my injury, and I am probably on these drugs for life. Every time I come off one, I've had a significant relapse and got much worse and not been able to recover my baseline. Now, we might be extreme ends, but we actually don't know. In Jakob's study here, he did make a comment in the paper that people who had been iller for longer tended to need longer therapy. I think it was up to 6 months in people who had been ill for longer than 6 months. But again, there's no way to know when is the right time to come off. And coming off can be a significant setback for some patients. So again, it's just something you need to consider with your patient and make sure they're fully informed and you're fully informed. And I think one thing that always comes up in the patient community is that doctors will take them off the drug and that will be it until their next appointment in 6 months. But I think this is such a fragile population of patients that as the clinician, you need to work with the patient, you have a plan, have a backup plan, be flexible and be accessible to the patient. Because at the moment they're coming off the medication, things aren't going right, they're not sure if it's normal, and then they're trying to decide, should I go back on it? Can I even get a prescription? Should I buy it online? So I think you need to just be available and flexible and have backup plans so the patient knows, if you feel like this, just go back on the drug and I'll give you a repeat prescription. The other thing to factor in is that earlier I said that treating the clotting might have secondary benefits for MCAS, but the flip side is that treating the clotting might trigger the MCAS. And I do know one patient who had their MCAS very well controlled with just lifestyle modifications. They came off all their MCAS treatments, were doing well from the MCAS point of view, started on triple therapy, and their MCAS came roaring back. So again, it just emphasizes that individual approach is needed. So I guess to summarize the considerations, it's unclear who's going to benefit, how much they're going to benefit, how long they'll benefit for. So I would kind of conclude saying, in my opinion, clotting seems significant in many long COVID cases, but long COVID is syndromic, so don't get myopic about it. Individual care is needed, including consideration and treatment for co-pathologies. Precautions are warranted. The risks are very high with this treatment, but as I'm sure you're aware with the MCAS treatments, the rewards are really high too, and the people who respond to this really do respond to it. But overall, there are many unknowns, which puts us in a very difficult position. These are my references which you can access here. If you find I've said something and you can't find a reference for it, please do let me know. On that note, I would like to say thank you. There's the reference link again.